Thank you very much, Jean-Louis. Thank you very much, Michael, and all the group for inviting me. It's a pleasure to be in Roma. Obviously, it's a wonderful city, and it's a wonderful place to be with you. As some of the authors here or speakers, I am a consultant for one of these sponsors, and I will go immediately to this determining factors for oxygen uptake and SvO2. On the top of the panel, you can see the Fick principle. This has been reminded by Keith Worley previously, and from this equation we can extract the SvO2 relationship. Just keep in mind that this is only approximately true since we just neglect the dissolved oxygen. So this is the equation, and what I will try to do is to make the link between SvO2 and cardiac output, since it's the title of my presentation. So remember, and I'd like to thank Jean-Louis Teboul for some of the slides he gave me, and we had a good time together in preparing this session. Remember that SvO2 will decrease when SaO2 will decrease, according to this equation that is above. It will decrease as well when hemoglobin decreases. Also when oxygen uptake will increase, because this is on the upper part of the relationship, and this might be due to awakening. This is an important aspect of our patients in the ICU or in the recovery room, when there is fever or shivering, when we use thermogenic agents, and we'll finish by that, sometimes it could be a problem. And this is true if cardiac output does not adapt to this modification, in fact. And so all these things will be modified, and the cardiac output in most of the cases will adapt. And so there is a strict interrelation between all these parameters that we keep in mind, and we have to keep them in mind in order to interpret SvO2. This is an example of hemodilution in young patients. When you consider the decrease in hemoglobin from 14 to 60 or 50 grams per liter, you can see that the SvO2 for a long period of time does not change. And this is due to the fact that cardiac index will increase at the same time. There is a point at which there is something that is changing, and this point is, let's say, a sort of alert or threshold beyond which we should not decrease. This is a value of 5 grams per deciliter. We don't have to remember the exact value because there will be critical hemoglobin value for different oxygen uptake, different cardiac outputs, and so on and so forth. But just to remember here that the value of 69% for oxygen mixed oxygen venous saturation is related, as Keith showed us previously, to an extraction which is only 30%. But as you can see here, if we project the line, and if we go for a value of 4 grams per deciliter, we should end up with an SvO2 around 40 or 50%. So this is certainly a step beyond which we should not go. So if we consider two different cardiac output, 5 liters and 2.5 liters, obviously this will have a very big influence on the value of SvO2. For the same value of hemoglobin, 7, you will end up with 40 or 70 of SvO2 due to the fact that the cardiac output is able to have that or not. And that is one of the reasons in our international recommendation, and this is true in most of the national recommendation, we take into account the cardiac profile of the patient in order to give blood or not, to transfuse or not transfuse. Although I would say these phenotypes that are proposed are very vague. In this very nice paper from Philip van der Linden, which is a classical hemorrhage experimental procedure in dogs, and in which they try to decrease the oxygen uptake by decreasing the oxygen delivery. Here the oxygen delivery has been decreased by hemoglobin, going from 16 to 2. You can see that in 2 different dogs, in one case the critical hemoglobin value is 3, and in the other one the critical hemoglobin is 6. And so the difference between the 2 dogs is that the oxygen uptakes are different, although in that case this should prevent lower or higher critical hemoglobin value, but we don't mind. But also the extraction ratio are different, and this is attested by the slope. The slope here is much steeper, showing that this dog is able to extract much more oxygen than that one. And so the understanding here is that we cannot consider an absolute value of hemoglobin, whatever this clinical situation. We have to consider a global integration of all these parameters. That's the reason why I think the reverse paper was so important for us, not only by optimizing the initial fluid responsiveness or the initial fluid administration of the initial dobutamine administration, but also because part of this trial was associated with a larger delivery of red blood cells, and again, hemodynamics to some extent at what point we'll have to consider the other source of treatment, and certainly transfusion is one of the important treatment when we consider oxygen delivery and tissue perfusion. So in the control group, there was only 18 patients that has been transfused against 64 person in the EGDT group, despite the fact that all the patients, the hematocrit was above 30%. In our group, we showed that if you follow guidelines, these guidelines here are related to this cardiac profile I suggested previously, whether it's 10, 9, 8, or 7, with different severity of the cardiac function. If you follow the guideline, or if you don't follow the guideline, the SvO2 could be in both cases low, or it could be in both cases high. And so even this SvO2, as presented by Keith, is a very global interpretation of the tissue perfusion and the oxygen extraction at the periphery. Nevertheless, it might provide you with something which is stronger than just the international, the national guidelines for transfusion. And so it takes into account, and this was one important point that Jean-Louis raised yesterday, it takes into account the individualization of your treatments. You take into account the patient that is really in front of you by using a physiological parameter to decide to transfuse or not. And when you consider the hemoglobin levels before and after transfusion, you can see that in the 4 groups, you cannot see much difference in between these patients. So if we go back to this very interesting algorithm, and if we take into account this SvO2, it might be true that for more than 75% we do nothing, but I will come back on that. Now, part of the interpretation will be related to the cardiac output and certainly to the hemoglobin, and I think I really try to stress on that point. Now the SvO2 can decrease per se because the cardiac output decreases, and the different determining factors of the cardiac output, the heart rate and the stroke volume put together, will help us to interpret the oxygen uptake to delivery relationship. And so the question we'll have for a patient is whether this oxygen delivery is adapted related to the cardiac output, the stroke volume, or the heart rate. I think that this has been used in different settings, and in that study from Rupert Peirce in London, we clearly see in patients in the recovery room after having had high surgery or heavy surgery, that some patients are able to keep in the recovery room and remember that's the place where the patient awakened. They can keep their SvO2 quite nicely, and others are not able to keep this SvO2 constant, and the SvO2 decreases below 70%. And so in those who had the constant, let's say the constant SvO2, the lowest SvO2 was much higher than in the other group, and the number of complications postoperatively was also smaller. And what was behind that? Behind that was the fact that the oxygen delivery was more or less adapted to the oxygen uptake. And again, in this awakening phase, the recovery room, there is an increase in oxygen demand. But let's see that the oxygen deliveries are quite overlapping in both groups, despite the fact that, again, in this high SvO2 group, the lowest cardiac index was much higher than the lowest cardiac index in the other group. So the idea for the oxygen delivery is that it's very difficult to use it to predict that the patient will behave correctly or not. And remember that monitoring is also a way to predict things. And this is due to the fact that, for example, in this normovolemic anemia, this is an experimental paper made in animals, for the same oxygen delivery of 10, you can end up with an SvO2 of 40 or an SvO2 of 60, and this is due to the fact that there might be different hemoglobin concentration behind that. And we also know that different critical hemoglobin value, despite the fact that the oxygen delivery is the same, could end up with different SvO2s. But much more importantly, the VO2s are certainly very different in all these animals. So all the work about the hemodynamics will deal with that, and this is not my job today, and so I will just keep that consistent with the fact that this is in the line of interpreting the preload, whether you use PAOP, whether you use echo, whether you use stroke volume variation, and so on and so forth. Now, let's progress a little bit. SvO2 is an integrated view on oxygen uptake to delivery balance. So SvO2 will increase when oxygen delivery increases. SvO2 will increase when oxygen uptake decreases, but also SvO2 will increase when oxygen extraction decreases, and this is a major problem. This is an interesting paper made from 4 prospectively collected registries of emergency department patients treated with the reverse recommendations, or the reverse principles, let's say it this way. And so they observed that in this 619 patients, there were 3 groups of patients basically. Those who were hypoxic, defined by an SvO2 below 70%, 62% of these patients. Normoxic patients, their SvO2 was somewhere between 70 and 90, and so this was 465, and so you can ask yourself what you can do with that. Most of them were finally somewhere normoxic. And also a small group, 92 patients, which is at least 1/7 of the group, were hyperoxic, means with an SvO2 larger than 90%, which could be also questionable, I think. But interestingly, I will not question the measurements by themselves, but interestingly, let's see that the mortality rate went down from 40 to 21 when you consider hypoxic to normoxic, which is quite logical and which is exactly related to what reverse would suggest. But interestingly either, the hyperoxic had a higher mortality rate, suggesting that something was really wrong, either at the level of the microcirculatory level or in the mitochondria themselves. So what can we do with that? We'll try to see what is the relationship between the cardiac index, the oxygen extraction, and the SvO2. So there is several ways to interpret the increase in cardiac index when you consider the SvO2. Either the oxygen uptake was DO2 dependent, and so we go from 40 to 40, we don't change. But despite the fact that SvO2 doesn't change, the cardiac index can increase anyway. The cardiac index can increase along with the same oxygen uptake, and in that context, there is just an increase in cardiac index without any increase in VO2. But you can also increase the cardiac index by using, for example, a thermogenic agent. And in that case, you have an increase in oxygen uptake with the increase in cardiac index. And so the view can be a little bit complicated. And so if we put that together, it looks like something like below the threshold of the oxygen delivery, the critical oxygen delivery. When you will increase the cardiac index by increasing the oxygen delivery, you will not change the SvO2 that much. After the critical oxygen delivery, there will be a big, big benefit of the increase in cardiac index as assessed by the SvO2, and the reverse patients were in this part of the relationship, I think. But afterwards, and this has been raised by Keith, can we say that the oxygen delivery is adequate or not by just considering the SvO2 that is high, and specifically in those patients who had oxygen extraction defects? So we have something like that in the relationship between SvO2 and cardiac index. For most of the patients, when we go in the very first part of the relationship until 70, we can say that this is beneficial for patients for sure. I mean, we don't have any concern about that. When we go from 70 to 80, it might be beneficial, but we don't know, and it's much more complicated to understand. Now, when we go from 80 to 82 or 90, can we say that there is no benefit of increasing cardiac output? That we don't know. So one suggestion would be to use another respiratory parameter, which is the CV, or the venous CO2, or the tissue CO2, by the way, or the central venous CO2, which is an approximation of the mixed venous CO2. And constantly, we need to include the arterial CO2 because the arterial CO2 will by itself influence the venous CO2. So the relationship, as you can see, is different. It does not go the same way, and it can help in those patients who are at this very higher part of the SvO2. This slope has been used from this paper we published with Fabrice Vallet. He made this study in Toulouse, and we consider the design together. And as you can see, in patients that has been admitted in the ICU, when they entered the ICU, the relationship either at the admission in the ICU, 6 hours afterwards and 12 hours afterwards, between the central venous to arterial CO2 difference and the cardiac index is quite linear. This has been found by the group of many rivers at the same time. When we split this patient into those who had a high gap and those who had a low gap, and this value was determined from a work from Jan Bakker I will show afterwards, we can separate this patient in two groups. And what we can see here is that for all the patients, 50 patients that has been admitted in the ICU, all of them had a high lactate, 6.5. And that was the reason why the group decided to optimize the cardiac output according to this strong lactate elevation. And so they used the PICO device in order to increase the cardiac output. And so you can see that when we split them into low gap and high gap, we still have very high lactate level, 4.6 here and 7.5 there. And the SvO2 is 78 and 75. So what is the key message here? Is that despite the fact that all these patients has been optimized according to the SvO2, they all end up with very high value of SvO2, but they are very different cardiac index, 2.7 and 4.3. And so we can presume that these two different cardiac index are not the same for the patient's requirements and for this cell respiration. And then when we split them into two groups according to the 6 millimeters mercury threshold, you can see that you have very different central venous to arterial CO2 difference, 8.9 against 3.2, suggesting that to some extent the relationship between the cardiac index and this value of metabolic demand was much better than the relationship you can use with the SvO2 per se. And this has been nicely shown by Jean-Louis Vincent and Jan Bakker years ago. They showed in this human septic shock patient in 1992 that when the DO2 and the VO2 was not very helpful in determining how strong was the difference between those who will survive and those who do not survive, the gradient of CO2 was there as a difference, 4.4 against 6. And this was a reflection of the lactate difference between the two patients. And they also proposed in their paper a relationship between the cardiac index and the central venous to arterial CO2 difference, although it was much it was not as strong as that one we found with Fabrice. Remember that the tissue CO2 is related to the number of perfused capillaries. This is a nice paper again from the group of Jean-Louis, and that the higher the tissue CO2, the lower the number of perfused capillaries, and that you can restore that by giving, for example, a small dose of dobutamine. Interestingly, the number of capillaries that are occluded and the higher the level of the CO2, the larger the lactate gradient as well. So to conclude, I would say that do nothing cannot be sufficient today, and I would propose that instead of do nothing, to consider the central venous to arterial CO2 difference, either it's below 6, and there I would say do nothing, or it's larger than 6 millimeters of mercury, and then I will come back to the hemodynamics variables, whether it's the SVV, the PEPO, and others, and I would say that if the SVV is below 8%, which is a preload assessment, then it's time to give an inotrope, because obviously you have a high gradient, but a low SVV, a low preload, a normal preload, and so you can consider giving an inotrope, and I think it's a nice way to keep going by rendering the cardiac output adequate. Also, I mentioned that in case you have an increase in metabolic demand, as shown by Jean-Louis years ago as well, by increasing dobutamine in those patients, you can see that sometimes the VO2 goes from 112 to 127 when they go from 10 microgram per kilogram to 15 microgram per kilogram of dobutamine. And so here there is an increased demand. The SvO2 does not change that much, but you can see that the venous to arterial CO2 difference, this has been measured on the Swan-Ganz catheter, increases again, suggesting that maybe the metabolic demand is larger than it was at 15 than it was at 10. So it might be an help in titrating treatment as well. So to conclude, when SvO2 or SvO2 is below 70 or 75, again, there is a difference between the two markers. It can be used to give initial hemodynamic resuscitation. And this is very helpful, I think, as a sort of pre-assessment of the patient in the emergency room or in the recovery room after surgery. You can titrate according to these values, the hemoglobin certainly, the SaO2, but also the cardiac outputs. This could be a bit empiric. When SvO2 or SvO2 is larger than 70, then you have to consider metabolic parameters. Certainly the lactate, it remains an important parameter to consider. But maybe the central venous CO2, just because we can imagine, and I would not say imagine, we can have intravenous device that will measure CO2 continuously. And the Paratrend did that in the past, and I think we can go back to this field in order to measure the venous CO2 continuously. A persistent central venous to atrial CO2 gap larger than 6 would either suggest to give more fluid or to give an inotrope. Thank you very much.